my name's Jenna. I'm a first-year physician assistant student. Today we'll be taking care of your abdominal exam as well as your musculoskeletal exam. So if you could please remove your shirt, shoes, and socks for me, which I see you've already done. And then please empty your bladder. And then I'm gonna go wash my hands, and then you can lay down, and if you could bend your knees up for me. Perfect. So first, let's make sure this is going. Yes. So first, I would be inspecting the abdomen for the contour and inspecting for any scars, striae, distension, masses, pulsations, and the condition of the umbilicus or umbilicus. Let me see it. Okay, tomato. And then next, I would also ensure that I could see from the xiphoid process down to the pubic symphysis, which you don't have to pull it all the way, but just, and then maybe could you turn with your feet pointing that way? Or no, your feet pointing that way, so sorry, it's okay. Just so I can see them. And so then I would start by auscultating after I inspect. I am going to auscultate all 4 quadrants, listening for the bowel sounds and noting whether they're normal, active, hypoactive, or hyperactive. And then if I don't immediately hear bowel sounds, I would listen for 1 full minute in each quadrant. And next I'm going to percuss all 4 quadrants, and I will also be percussing for splenic enlargement. And then I'll be noting the sounds of dullness or tympany. And then for the splenic enlargement, I'll be percussing the most inferior intercostal space and the anterior axillary line, as well as the costal margin on the patient's left-hand side. Okay, and then next, for palpation, first I would ask the patient if she has any pain in any areas and ask her to point to the area of pain, and I would palpate that area last. So when I palpate, I'm going to be watching her face, looking for any signs of distress. So first, I'll be palpating lightly, about 1 centimeter, watching her face for any signs of distress, and feeling for any superficial masses. And then next, I will palpate deeply at about 4 centimeters, again watching her face, but this time palpating for deep masses. I will next palpate for splenic enlargement and ask the patient to take a deep breath in and relax. And then I will palpate for enlargement, masses, and tenderness of the liver. And again, take a deep breath in. Okay. And then next I will have the patient sit up. So if you could, perfect. And I will test bilaterally for CVA tenderness. So with my hand posterior, let's see. Any pain? Any pain?
Nope.
Okay. And then lastly, I would do a rectal exam. So then next for the musculoskeletal exam. Okay, so for the musculoskeletal exam, I will be inspecting and palpating for muscle atrophy, for any abnormal movements, crepitus, the condition of the surrounding tissue, any inflammation, edema, effusions, ease of the range of motion, inflammation, malalignment of the bones, any tenderness, and then also inspecting and palpating inspecting for symmetry. So first, I actually have you turn this way. With your back towards the camera. So if you can move your hair for me. So first I'm going to be inspecting the, I'll be on the patient's right side. I'll be inspecting for the alignment of the shoulders and the pelvis, and then I'll be inspecting the area over the scapula and trapezius, and also the area over the spinous processes and the paravertebral muscles. Then I will be palpating the spinous processes, as well as the paravertebral muscles. I'll also inspect the sacrum, and then I will palpate both the sacrum and the sacroiliac joints. And then I will assess her posture posteriorly and anteriorly, and then if you could turn and face me. And then from the side, I would inspect her posture laterally and inspect both the lordotic and kyphotic spinal curvatures. And then next I would assess the active range of motion of the cervical spine. So if you could tilt your chin towards your chest for me for flexion, and then back to neutral, and then extend your head back for me for extension. Perfect. And then next we'll do rotation, so if you could look towards the camera, and then back to baseline, and then look the other way. Thank you. And then next we're gonna do lateral bending. So without moving your torso, could you touch your ear to your shoulder? Perfect. And then back to, and then the other way. Perfect. Okay, and then next we will be assessing the thoracic and lumbar active range of motion. So if you could bend forward for me for flexion. Perfect. And then actually I'm going to stabilize the patient. So if you could bend forward for me. All right. And then extend back. So you lean back. Perfect. And then if you could rotate to our right. Okay. And then rotate to the left. And then you can back baseline. And then bend to the side, either side. Okay. And then come back up and go to the other side. Perfect. Okay. Next for the temporomandibular joint inspection and palpation, I'm going to have the patient open and close her jaw, and then lateral movement of the temporomandibular joint, and then protrusion and retraction. Okay. And then next I'll be moving on to the shoulders. So I'm going to inspect the scapula, and then I'm going to inspect the clavicle, acromioclavicular joint, the proximal head of the humerus and the acromion. And then I'm going to palpate bilaterally the scapula, acromioclavicular joint. Put it over here. And then I'm going to palpate the bicipital groove and tendon. And then I'm going to palpate the clavicle, the acromion, okay, and then I am going to move on to the arm and elbow inspection and palpation. So I'm going to inspect the biceps and the triceps of both arms, the antecubital fossas, the okernon processes, and then both the medial and lateral epicondyles. And then I'm going to palpate all these same areas again. So palpating the anterior and posterior arm, the okernon process, and then I'm going to palpate the medial epicondyle and the lateral epicondyle. Let me do this for both arms. Okay, and then next we'll move on to the forearm and wrist inspection and palpation. So I am going to inspect the full forearm, both anteriorly and posteriorly, and then I am going to inspect the area over the carpal bones, as well as the ulnar styloid and the radial styloid. And then I am going to palpate. So palpating the ulnar styloid, the radial styloid, the carpal bones, anterior forearm, posterior forearm. And then next I will be inspecting and palpating the hands and fingers. So inspecting the area over the metacarpal phalangeal joints on both sides, and then inspecting the interphalangeal joints. And then I'm going to palpate metacarpal phalangeal joints and the interphalangeal joints on the sides of the fingers. All right, and then next we'll move to the active range of motion for the upper extremity. So first we'll do the shoulders. So we're gonna start with extension. So you can lift your arms up, and then flexion. Wait. So okay, rewind. First we'll start with flexion, and then extension, putting the arms down. All right, and then next we will do internal and external rotation. So you can, let's see, we can do it one of two ways, but we'll start with external rotation. So if you could put one arm up and over, and then do the same with the other. Wait. Yeah. And then internal rotation, you could put your one hand behind the back, and then the other side behind the back. Okay. And then next we'll do circumduction. So with the patient's arms at a 45-degree angle, I'll just have you rotate in front. Okay, perfect. And then next we'll do adduction and abduction. So first we'll start with abduction. So if you could raise your arms up like that. All right, and then bring them back down and then bring them in for adduction. All right, and then next we'll move to the elbows. So we'll first start with flexion. So if you could put your arms up like that, okay, and then extension. And then we'll do pronation and then supination. Okay. And then next we'll do the wrist joints. So we'll start with flexion, and you can lift towards yourself and then back to baseline and then extend. And then next we'll do ulnar deviation. So if you could bring your arms, and then radial deviation, putting them outwards. All right. And then lastly, we will do finger and thumb, flexion, extension, abduction, and opposition. So they probably want to see it. So if you come in closer, so let's see it. We just wait there so I can see it. And yeah, it's down more. So if you can bring your thumbs in and then make a fist with, okay, perfect. So that's the flexion, the thumb and finger flexion, and then keeping your thumbs in, kind of an extension, and then bringing the thumbs out for thumb extension, and then bringing the thumbs in for thumb adduction, and then finger abduction, bringing the fingers out, and finger adduction, bring the fingers in. Next we have thumb adduction. So if you could bring your thumb up like that, pointing towards the sky, perfect. And then thumb opposition, so touching your thumb to each finger, perfect. Okay, so next we will move to the lower extremity. So I'm gonna have the patient lay down. Okay, so for the lower extremity, first I am going to be inspecting. So I am inspecting the anterior superior iliac spine, the greater trochanter, and the hip joint. And then I am going to be inspecting the patella, the patellar ligament, the medial and lateral femoral condyles, and then the tibial tuberosity. And then coming down, I'm obviously going to be inspecting the full leg and calf regions as well. And then I'm going to be inspecting the lateral malleolus, medial malleolus, the Achilles tendon on the posterior side, and then the carpal bones, the toes, and then I will also be palpating the calcaneus. So coming back up, I will be palpating. So first I'll be palpating the anterior superior iliac spine, just a generalized hip joint, and the greater trochanter. Okay, and then the legs, and doing the same 3 major landmarks on the other side. Coming down, now I am going to palpate the patella on each side, the patellar ligament on each side, and the tibial tuberosity on each side, as well as the medial femoral condyles and lateral femoral condyles. Coming down, again palpating the anterior calf and posterior calf. Palpating the Achilles tendon, and then the medial malleolus and the lateral malleolus on each side. And then I'll be palpating, hope they can see that. Oh, barely, okay. And then I'll be palpating each foot, the metacarpal phalangeal joints, and then the tarsal bones and calcaneus on each side. And then I'll be palpating each of the interphalangeal joints of the toes from the sides. All right, lovely. And then we'll be doing passive range of motion. Okay, passive range of motion. So first we'll do hip flexion. So, good. And then we'll also do knee flexion while we're here, and knee extension. And then we'll bring it down, do the other leg, and extension. And then we're going to do internal and external rotation of the hip joint. So internal rotation, external rotation. Same on the opposite. External rotation, internal rotation, external rotation. And then next we'll do adduction and abduction, starting with abduction of each leg and adduction and abduction and adduction. Okay. And then I'll have the patient roll on her side for hip extension. Okay, and then if you could roll to the other side. Okay, perfect. So we've already done knee flexion and extension. So we're going to move down to the ankle joint, where we'll do passive dorsiflexion and passive plantar flexion. And again on the opposite side. We'll do inversion and eversion, inversion and eversion. And then lastly, we'll do active range of motion of the toes. So I will stabilize the metatarsal phalangeal joint, and I'll have patient flex, okay, and flex, and extend, and extend. Okay, and then lastly, I will measure the calf circumference using the widest point of the calf. 13.5. And then I will measure the active range of motion of the knee flexion. So I will have the circle the center of this going under on the lateral femoral condyle, and have the other arm of it pointed towards the greater trochanter, and I will measure that angle. And it is normal at 135 degrees.